The Mind Center is pleased to be co-hosting the Brain Health Inequities Symposium as an activity of Brain Health Awareness Week. Today's event is partially funded by the Dana Foundation through their Brain Awareness Outreach Grant. Partners in this program include the Mississippi State Department of Health, Office of Community Health Improvement, and the Jackson State University School of Population Health. I would like to thank the Jackson State University doctoral students, Brandon Neighbors, and Boteed Porter Medley for their work in making today's program a success. I hope you found the information in our advocacy portion insightful and helpful as I did, because as you heard today, it is our collective voice that is going to help those that are living with Alzheimer's disease and other dementias and their caregivers. Our guest speakers for the Brain Health and Equity Symposium include Gabe Ibarra, PAC, Dr. Ardarian Pierre, Dr. Sonia Shipley, and Dr. Kina White. Gabe Ibarra is a physician assistant specialist in Canton, Mississippi. He graduated with honors from Mississippi College and has more than 3 years of diverse experience in primary care and family medicine. Gabe is affiliated with St. Dominic's Jackson Memorial Hospital and works with many other doctors and specialists in the MEA Primary Care Plus group. Today, he will join us to discuss barriers he recognizes in access to care in the Hispanic community and their impact on brain health. You will notice now we were going to begin a slide presentation for the duration of this program. If you're on the phone, we will provide a recording of this at a later date. So please now join me in welcoming Gabe.
Good morning.
Good morning, thank you.
All right, don't know if I'm on or not. I could just see the PowerPoint. Is everything working on you guys then?
It is, thank you.
All right, well, my name is Gabe Ibarra. It's a pleasure being here. Great information from the previous speakers and very enlightening and a lot of things to consider. One of the things that I wanted to start with is our growing population. And so we can flip over to the next slide. This is something that, the numbers are going to start to grow. And for me, one of the things that I found enlightening was the difficulty in calculating how many Hispanics actually live in Mississippi. When I was going to get employed here, they're like, well, we don't know if there's a great need for you to be here because we don't know if this population is in necessity of it, which I would tell them, I was like, well, I don't see that many Spanish-speaking providers to begin with here, where if you go on a Google search, how many are you going to find? One of the things that I told them, this is the difficulties that we have in estimating the growing population. Here, for instance, in Canton, one of the things that we found was that there are multiple households living in the same house, and there's not an accurate number of an easy way to calculate. Is it 15 people live in the same household? Is it 8? It's definitely not more than 20, I hope, but we don't have a good way of estimating that. And there's also been a fear of census because of the recent ICE race that we had, that the Hispanic population is still in fear that if they report the numbers or report who they are, that they may get swept up, and therefore they don't want to participate in being counted. One of the other things that I see quite often is transient workers, as far as coming to Mississippi, working construction jobs and then leaving. But for instance, there's quite a bit of Amazon being built here, a couple apartment complexes being built here. When the coast gets reconstructed, there's an influx of Hispanic communities that come in following that work. So as long as there's construction, I would say there's a potential for more Hispanics to, be represented in our population. In our next slide, we move to there we go. The shifting demographics. This is one of the things that we wanted to share is the numbers don't expect to go in the opposite direction. We're going to see an increase in demographics as far as the number of Hispanics, not just here in Mississippi, but nationwide. And of special importance is, what we're here to talk about, which is Alzheimer's dementia and how it impacts this population. And more so, trying to figure out what it is that is making these numbers swell more so than anybody else that is non-white Latino, and why it is impacting there. And so there's a lot of things that I'm going to share today that may help elucidate some of these things. But one of the things that I hopefully accomplish today is helping anybody identify that there's a problem and necessity of providers that speak Spanish, and as well as understand that these numbers are going to get, worse. But more than anything, anybody who has any questions anytime, please feel free to put them in the chat box and reach out so that we can address those as well. If we go ahead and go to the next slide, our cultural beliefs of Alzheimer's, dementia, depression, ADHD, anything that's related with mental health. In the Hispanic community, and I mainly speak from where I come from, I was born in central Mexico and raised in Texas, but spent most of my time in Mexico during the summers. These items here, Alzheimer's, dementia, depression, ADHD, are in our community, but the way we handle them and deal with them is a culture is completely different. For instance, there is not a lot of nursing homes or skilled facilities in the states of Mexico, and much less in other southern countries that are much poorer that don't have those resources. So a lot of the time in the family, we recognize that someone is starting to lose their mind, whether it be Alzheimer's, dementia, someone in the family is going to take that loved one in and burden the care for them, whether they're trained for it or not. The family is always going to take care of their loved ones versus sending them somewhere else. And you bring that here to the United States, that's a little bit more difficult, where it may just be a small part of that family. Instead of 20, 30, 40 family members, there may be only 5 or 6. And so that burden becomes a little bit heavier here in the United States because they don't have the extra family resources that we do back home in Mexico, Guatemala, or anywhere in Latin America. One of the things that we also notice that with dementia, we come to accept that that's a natural progression of just being a human being. And we see that the medicines sometimes don't help and actually see more of a decline. Whether that's true or not is something that we just rather say, if we can treat it naturally or take care of them or understand that we just need to look after our loved ones, a lot of the Hispanic communities would rather do that than to try a new quote unquote experimental medication that may or may not work. Depression is something that we deal with and struggle with quite a bit, but it is very poorly understood in the Hispanic community because they just see it as not working hard enough, not putting forth a lot of effort, and in the long run, not addressing it with either therapy or medications at any given time. So one of the things that I struggle with in my practice here in Canton is dealing with depression and having them understand that depression is a real illness that needs to be addressed. And so treating the family members that have loved ones that they take care of because they have dementia is a source of depression that oftentimes don't realize that the healthcare taker of someone who suffers from Alzheimer's and dementia, they suffer from depression because they're seeing the decline and feel helpless to try to help their loved ones. The latest one, ADD and ADHD, is something that we really don't diagnose or have a public school system in our countries. And so one of the things that always shocks folks when I talk about Hispanics is when I came to the United States, this was the first time that I had free school. For us, if you don't pay for school, even if it's a poor school, there is no access to education, which also helps the mental decline and the lack of understanding for, lack of education. When I talk to my patients, I have to use a lot of pictures, diagram, a lot of anatomy. But when it comes to the brain, there's not anywhere that I can point to the brain and say, here's the Center for Depression here. Here's the Center for Alzheimer's here. I could show them different images of different brains, but to them, it doesn't really make that big of a difference. The difference they want to see is, can you help us? Is there a medicine or a treatment that you can do? And for a lot of them, it's having that leap of faith that they came and saw a provider that they're looking for more paternalistic type medicine than it is a shared decision, because they don't have the ability to do so. So that's one of the struggles that I've seen. And then the lack of finances, because a lot of these communities, a lot of these households, their daily struggle is, can I make my gas money? Can I make my grocery money? And they will put their health last. And so when it comes to screening for Alzheimer's, screening for depression, coming to the doctor regularly to stay on top of those things, they will put that on the back burner and put groceries in their fridge on their table before they'll do that. And I've personally seen that in my own family. Go ahead and go to the next slide. One of the things that I struggle with the most, me personally as well, is, trying to help my patients understand that diet, exercise, and the way we live here has a deep impact on our health, both mentally and, more importantly, if we don't take care of that, then we do have to end up on treatments and medicines. So I've been in Mississippi for 4 years, and unfortunately, my sugars got the best of me. I went from an A1C of 11 to 4.8 in 3 months after I realized I got to stop eating what I eat here, because I was not built to eat fried food all the time. And so in the Hispanic community, one thing that I want to share to any providers out there is that the foods that we eat are not just for comfort food, but they're really detrimental. And one of the things that I try to share with everybody when we try to clean up our diet is, if we don't understand that we eat tortillas with every meal, it's not just 1 or 2 tortillas. And sometimes they're homemade, and their homemade ones taste the best, but they're actually hurting us because that's all we eat. We put butter on them and slide them in, and that's our meal for the day. There's no peanut butter jelly sandwiches, there's tortilla sandwiches and tortillas with every single meal. So one of the things that I try to address is the cholesterol, because when I check someone's cholesterol, it's always hypertriglyceridemia, LDL is high, HDL is low, and it all has to do with what we're eating, and also being more sedentary. In most countries, we used to walk a lot, move everywhere, because transportation was not there, so everybody had to be more active. Now we're in the United States, where if I'm going to go from Richland to here to Madison or Canton, I'm driving everywhere, and there's no time to sit there and walk, because a lot of them will express this: when I get home, I'm tired from my job. I don't want to or have the energy to go do something. And then I didn't eat all day, so now it's time to eat. And the first thing and the first meal we put in there is something fried, greasy, that makes us feel good, but it's not necessarily good for our lives. One of the things that I like to share is, a lot of times a Hispanic patient may come into your office and say, I would like to have my cholesterol checked because I feel that my heart has grease around it, or it's just weighing me down. I think that my cholesterol is causing this chest pain. For me, I always have to explain what cholesterol does as a building block and try to strip it down so they have a better understanding. And of course, address the cholesterol problem. But at the end of the day, it's a dietary problem that we have not been able to get a hold of for lack of, good energy food and understanding. And again, some of this goes back to just lack of general education. Go ahead and go to the next slide. Can we move to the next slide? There we go. One of the best things that I can share with anybody is the barriers that we have here in the United States, and especially Mississippi, with language and lifestyle barriers. I'm still personally looking for someone to schedule my patients here at NEA and at St. Dominic's so that they have access to me. And a lot of the times we see child translators, but some of the medical problems that we have are not age appropriate for a child to be translating. And especially when it comes to mental health, a lot of the families have shame that they're coming in for depression, or shame that they're coming in because they're noticing something wrong with their brain. And the only source of translation for them to speak with a provider is through a child. And for a lot of that, they just choose not to be treated for those reasons. And when we have translation services, I've used some of them in the past before. And those translations, sometimes there's not 100% clear-cut communication because the interpreter takes it upon themselves to summarize what the person is trying to say versus what exactly they're trying to express. And so one of the things that we have as a barrier is understanding why anybody migrated to Mississippi or anybody migrated to the United States. And a lot of the times they're coming from places where crime and poverty, where they're trying to provide for their loved ones back home, and the type of work that they do, all of those are key components and factors to understand what it is that we need to provide for this community. When I see somebody who's a laborer, I always worry about their orthopedic problems. When I see that somebody's here escaping crime and poverty, I always worry about mental health issues such as depression. Were they human trafficked here? Is there other underlying conditions? So those are the key questions that I always ask. And with the poverty comes, did they ever get vaccinated? Did they ever get good nutrition? Is there other physical problems that we need to address because of where they're coming from? Was there a lack of anything that they basic needs that they needed? And addressing those, because those are all the building blocks towards bad mental health in later years. And I always believe in the prevention of all these things will always be more cost effective for any household and anybody out there. But just simply understanding where and why these folks are coming here is an important track, because not everybody's coming from major city or metropolitan areas. They're coming from poor farms where there's no work. And so they're willing to take on any work themselves to death, and work 10, 12-hour days, multiple days in a row, and wear themselves out. So they don't look age appropriate. They look older than what they appear. I see several 30-year-olds and I'm looking at them. I'm like, I'm not trying to say you look rough, but you look like you've aged and you're actually 50, 60 years old, and their body reflects it as well. One of the things that I challenge anybody who sees these Hispanic folks is to ask themselves, please tell me about yourself. Where did you come from, so that I can understand how to take care of you? Let's go ahead and go to the next one. I wanted to share a couple cases so that we can get a better example of what we're dealing with. So my first patient was an 84-year-old female patient. They came in the clinic that followed up from St. Dominic's Hospital, and they found me because they had the little bulletin board says, "He speaks Spanish." She really needed to be in the hands of an internal medicine doctor to manage all the comorbidities that she had, because basically she landed in the hospital. But when she came to my clinic, I had all the family members in the room. This is before COVID. And some of them had driven all the way from Texas because they wanted to take care of grandma and mom. And all of them wanted to take them to their own house and make the medical decisions for her. I asked her how she felt, and she was like, everybody just is doing everything for me. I don't know what to do. So at that point, I asked everybody to leave the room and did a mental health assessment on her. And I said, let's talk about this. They're saying that you have dementia. They're saying that they're taking your car keys away from you because you drove to Louisiana and you got lost. I was like, are you aware of this? It's like, I get lost in my own house, she told me. And I was like, well, here's where we need to figure this out. Are you capable of making your own medical decisions to keep yourself safe? And so one of the things that I told her is like, depending on where you are with this, we do need to have some sort of family involvement. But if you're clear and can make your own medical decisions, the family is going to have to respect that, and they're not going to take that news well. Because in our culture, again, we're asked to look after our loved ones. And so sure enough, when they came back to the room, I had to speak with every single one of them individually and give them their individual time to air what they wanted to do, because none of them were on the same plan. One of them was like, I had already talked to mom and I'm taking her back to Texas and she's going to live with me and we're going to take care of her. We have a doctor back home. The rest of the family is like, well, mom's house is here and we're looking after her and we'll decide that later. No one ever bothered to ask mom what she wanted to do. And that's one of those things that I tell them. If she has dementia, if she has Alzheimer, she's going to be robbed of her memories. and her dignity, but not the ability to always not be able to make a decision. So if she's well enough to make decisions now and wants to put down on paper what she wants done with her health, we have to address that now. Otherwise, there's going to be nothing but fights that I see constantly when I work in my nursing homes, where the patient wanted to be a DNR. The patient did not want to be operated on if in case they need an amputation. The patient needed XYZ. In the Hispanic communities, we don't make such plans, but I always make that challenge now from here forth. Tell me what it is that you want me to do in the event that you cannot make decisions for you. Put that on paper, discuss it with your family members, because they will make decisions for you. And if you have more than one child, they're going to have difference of opinions. And this mother, my patient, heard the disarray and started making decisions right there on the spot and said, look, this is what I want. She even planned her funeral, was very happy about how that was going to go down. And she said, when I'm ready, I'm ready. I've had a good life. And everybody needs to be on board with that. I was like, you put that on paper, we'll get it legalized. And we'll make sure that that's what we're going to respect. So when she got COVID, she made a decision that she didn't want treatment. At that point, her dementia was pretty bad. She said she did not want any treatment. If anything was going to happen, she just wanted to go out the way she came in. And so at that point, one of the other things that we don't talk about is hospice. Hospice is one of those things that we don't have, and therefore we decided to, try it, and it worked out pretty well for her. So that's just one of the cases. I have others, but because of time, I just want to be considerate and give everybody else an opportunity. But if you guys have any questions or need somebody to reach out to, please feel free. I thank you for you guys' time, and I hope some of this information is helpful.
Thank you, Gabe, so much. As you can see, please put your questions in the chat, or we will also have a Q&A at the end of the symposium in an hour. So I hope that you will write down your notes or put them in the chat box. Again, thank you, Gabe, for your insight into brain health and care disparities in the Hispanic and Latino communities in Mississippi. You have certainly opened our eyes and set a stage for more dialogue that is needed as we work to address health inequities and caregiver inequities in Mississippi. So appreciate that. Hope that we will continue that conversation. Now, I would like to introduce Dr. Pierre and Dr. Shipley. Dr. Pierre earned her doctorate of medicine at the American University of Antigua, New York. In 2015, she joined UMMC as a geriatric fellow and the UMMC faculty as an assistant professor of family medicine. In addition, she provides diagnostic assessment and treatment for patients in the Mind Center Clinic. Dr. Shipley earned her doctorate of medicine degree from the University of Mississippi School of Medicine. Dr. Shipley has 2 offices in Mississippi at UMMC and Baptist Medical Center, where she specializes in family medicine. Dr. Shipley provides comprehensive medical care and is generally the first point of contact for patients seeking general care. She also provides diagnosis and treatment for patients in the Mind Center Clinic and is the primary provider for their telemedicine program called TeleMind. Today, Dr. Pierre and Dr. Shipley join us to discuss brain health inequities in Black American communities and ways to promote brain health. Please welcome me and please join me in welcoming Dr. Pierre and Dr. Shipley. First, we'll hear from Dr. Shipley on brain health inequities in Black American communities.
Can everyone hear me okay? So
yes.
I just want to say thank you so much for the invitation, and Dr. Pierre and I will tag team this presentation, if you will. So we'll just hop right to it. So the information presented in the initial portion of this presentation comes from a 2021 Alzheimer's special report about race, ethnicity, and Alzheimer's in America. And so the Alzheimer's Association actually reached out to patients and caregivers of color to ascertain challenges to receiving care in this current healthcare climate. So these figures on this initial slide may be familiar to you. Alzheimer's is the 6th leading cause of death in the United States for those who are 65 and older. However, it is the 4th leading cause of death for older Black Americans. And sadly, Black Americans are 2 to 3 times more likely to get this disease than white Americans. And we will go into more detail as to why that may be the case in later slides. The amount of Americans with the disease is huge, 6 million folks currently living with this. And though only 20% of the patients are Black, approximately a third of the national cost for dementia care is spent on these particular patients. Next slide. So when we look at the prevalence of Alzheimer's disease, it increases dramatically with age. If you look at the color coding, the black bar is white Americans, the purple bar is Black Americans, and the gold bar is Hispanic Americans. And as you can see, the disease burden is incredible for Black Americans as well as Hispanic Americans at all ages. In fact, it is 2 to 3 times higher than that of white Americans. Next slide. So, as I mentioned, we're going to touch on a little bit on why we think this may be the case. And so you may have heard the terms health disparity, healthcare disparity. And so I just wanted to make sure that we are all using the same words, that we're all using the same terms to explain what we mean. So when we say a health disparity, what we mean by that is a particular group of folks experience a higher burden of illness or injury, disease, death, versus another group. When we say health care disparity, we are talking about the differences between groups and their ability to access care, receive insurance coverage, as well as the quality of care that you receive. Sometimes these words are used, or these two terms are used interchangeably because they are so close, but they do mean slightly different things. The important takeaway is that these differences are not explained by variations in the healthcare needs of the patient's preferences, or treatment recommendations, and they are very, very closely linked to social as well as economic and environmental disadvantages. So when we look at health and socioeconomic inequities, we know that there's an increased prevalence of vascular-related medical conditions in our patients of color. And those conditions include things such as high blood pressure, diabetes, stroke, high cholesterol, and those things are major risk factors for developing dementia. Other inequities that can contribute to not having excellent brain health is also barriers to higher education. So low educational attainment has been associated with developing symptoms of dementia earlier. In fact, dementia could present up to 8 years earlier because of differences in educational attainment due to socioeconomic challenges. The other thing to think about too is access to healthy diet and nutrition. which subsequently can lead to higher BMI and obesity. And those are factors that can also negatively impact brain health. So as I mentioned, a lot of these facts and figures come from a survey that was performed by the Alzheimer's Association. And so when they polled patients and caregivers, one really big barrier to care was discrimination. In fact, about half of patients of color reported that they had experienced discrimination when attempting to seek care. And not just the patients, the caregivers also mentioned that they too face discrimination when attempting to navigate an already challenging healthcare setting for their loved ones. Older Black and Hispanic Americans, in addition to having a disproportionate burden of disease, they are also much more likely to be misdiagnosed. So that's another factor that limits patients' ability to receive adequate care. Next slide. So multiple barriers to care exist. And one of those barriers to care that came out in the course of the survey was access to medical providers of a similar background, or if not a similar background, at least a healthcare clinician who understood their background, understood their experiences. And during the course of the survey, basically, most people felt like they wouldn't really have the ability to access culturally competent care. Also, the survey looked at research. And interestingly, about 2/3 of Black Americans felt like medical research was biased against people of color, and as a result, were not interested in participating. The patients had less interest in participating in research, but interestingly, the caregivers were more interested. Another barrier potentially to care can also be the affordability of that care, as well as lack of comprehensive coverage. Other things that came up in the survey were some further cultural considerations. So most Black Americans surveyed felt like even if a future cure came to pass, that it would not be equally shared across races or ethnicities. So that is quite concerning, that there is a huge lack of trust. As previously mentioned, people of color don't tend to see a doctor as quickly when memory difficulties develop, because a lot of people just assume that's just kind of a normal part of aging, and it's not necessarily a normal part of aging. Next slide. So implications for healthcare providers. So again, we've been talking over and over again about barriers to receiving adequate care. And one of those things that is a big deal is a physician's shortage. When we look at the number of geriatricians we have in the state of Mississippi to provide care for older adults, I think the last figure I looked at said maybe we have about 25 folks, but we need over a 300% increase to provide adequate care. Also, for patients of color, there have been some studies to come down the pipeline in recent years that talk about the fact that physicians and various providers of color are more likely to provide care to underserved populations. They're also more likely to go to underserved areas and provide care. And so again, not having adequate numbers of clinicians, B, a diverse workforce really can have huge implications for receiving adequate care. Fortunately, the university has been heavily invested in telemedicine even before COVID. And so quite a few of our patients throughout the state do have access to telemedicine services even before COVID. And then, of course, affordability can be a big challenge.
Thank you so much, Dr. Shipley, for that information. And continue to make your comments in the chat box, and we'll have questions afterwards. Now we'll have Dr. Pierre on ways to promote brain health.
Good morning again. I'm so excited. Can you hear me? Hello?
Yes, we can hear you. Thank you.
Okay. I'm so excited to share in the symposium with you all today. So we'll just continue. Risk factors for dementia. As listed here, we have cardiovascular risk factors, unhealthy diets, physical inactivity, age. Again, as we get older, research shows greater than age 65, your risk for dementia is increased. Inflammation, diabetes, especially when uncontrolled, smoking, depression, excessive alcohol use, social isolation, and loneliness. All of these factors can increase your risk of dementia. As seen here, we have poor, intermediate, and ideal cardiovascular health adults. Research was done on these patients ages 20 to 49 years of age and greater than 50 years of age. As you can see, current smoking increased your risk by a percentage of 82%. Healthy diet score, the score was higher, and blood pressure increased your risk as well by about 50%. So taking care of your physical health, it is important to maintain goal blood sugars. Paying close attention or careful attention to your blood pressure and the control of which can decrease your risk. Treatment of high cholesterol. So there are a number of medications today that we use to keep these numbers under control. Diet is also an important factor for controlling your cholesterol. Reducing risk for brain injury, so falls, accidents, sports injuries, and again, smoking cessation. It is important to avoid medications which may have adverse effects on your focus, your cognition, and or your memory. In patients who are depressed or have a history of depression, it is important to be seen and or evaluated and have that optimally treated, which will help reduce the risk as well. Getting recommended health screening, so screening for things like colonoscopies and so forth. Also, getting your immunizations on time are important things to take care of. Staying physically active. Exercise actually stimulates the brain's ability to maintain old and form new neural connections vital to cognitive health. Increases size of the hippocampus, frontal, and prefrontal cortex. Brain structure is important to memory and learning and improving spatial memory. Reducing insulin resistance and inflammation is one of the benefits of staying physically active. And it also reduces the risk of stroke and heart disease. Aerobic exercise is thought to be more beneficial for brain health than any of the other factors. There are specific programs to promote safe, balanced movement. Balanced movement can also prevent falls and other injuries, which may put your brain at lower risk for developing dementia. So indirect brain benefits of exercise, positive effects on the mood. I know oftentimes each morning I try to get up and do a 3-mile walk, and I do notice a difference in my mood for the day. So it does make a difference. Improve sleep, as long as you're not too close to bedtime, that makes a difference. And reducing stress and anxiety. Next slide. So there's good evidence that says what we eat does make a difference. It can decrease cognitive decline and therefore decrease your risk of dementia. As a result, we do recommend that we eat a MIND diet. MIND stands for, is actually a hybrid of two popular diets, the Mediterranean diet and the DASH diet. The DASH diet stands for Dietary Approaches to Stop Hypertension. So this approach specifically includes foods and nutrients that medical literature and data have shown to be good for the brain. Next slide. So here are just a few of the foods that are recommended. It is recommended that we eat at least 10 from each group. So the green leafy vegetables, spinach, lettuce, kale, collards, nuts, berries, beans, whole grains, fish, poultry, olive oil, and wine. Yes, I did say wine. We'll expound on that shortly. So to just kind of sum this up, it's pretty much a high fiber diet, and low saturated fats and low added sugars. Next slide. So just a few foods that we should avoid. Red meats can be consumed, but it is recommended that we consume them sparingly. Butter and margarine, cheese, pastries, sweets, fried and or fast foods. Again, these foods are included as those to avoid because of the high saturated and trans fat content. Next slide. So what are the benefits of the MIND diet? So research does show that eating certain foods and avoiding others has been shown to slow brain aging by at least 7.5 years. So people who stuck with the diet lowered their risk of Alzheimer's disease, by about 54%. Adults who followed the diet only part of the time still reduced their risk by about 35%. So here we know that, diet does make a difference. It is promising and it is still being researched. So more to come. Now, one of my favorite fruits are certainly blueberries. We know the saying that an apple a day keeps the doctor away. Well, apparently, so does blueberries. Blueberries are known as a superfruit. They are loaded with antioxidants and flavonoids, shown to increase memory or improve memory, reduce your risk of heart disease, cancer, as well as Alzheimer's. In a 20-year study of over 16,000 older adults, those who ate more blueberries and or strawberries had the slowest rate of cognitive decline. There also has been shown to have an improvement to access to words and or concepts. So eat your blueberries. Next slide. It is also important to eat breakfast. It is the most important meal of the day. Eating breakfast may improve your short-term memory and attention. Foods at the top of the brain fuel list again include high fiber, whole grains, dairy, and fruits. The key is avoid overeating, as high-calorie breakfasts appear to hinder your ability to concentrate. All right, dark chocolate. It is okay, or it is recommended to add a daily dose of dark chocolate to your diet. This is a powerful antioxidant, and it contains natural stimulants which naturally enhance your ability to focus. Enjoy up to an ounce a day of dark chocolate with a minimum of excess calories, fat, and sugar. Dark chocolate is one of my favorites. Now, to go back to alcohol intake, women, it's okay to have less than 1 drink a day, and for men, less than 2 drinks a day. And to define a drink, 12 ounces of regular beer, 5 ounces of wine, and 1.5 ounces of 80 proof distilled spirits. Again, this is the recommended amount of alcohol intake for men and women. Next slide. So what about vitamins, minerals, or supplements? So, we get this question all the time. Dr. Pierre, what's a good vitamin? What vitamin do you recommend? First off, it is always best to get all of our nutrients, all of our vitamins naturally from our diet, as opposed to taking a pill or taking a supplement. Too much of any vitamin or mineral can be harmful rather than helpful. So ongoing investigations on a variety of complementary health approaches, as well as diets for preventing or slowing the progression of dementia, are underway. There's no strong evidence that any can prevent cognitive impairment. Again, we have discussed the Mediterranean and DASH diet, which have proven to be helpful. Many reports on brain boosting power of supplements like vitamins B, C, E, and beta carotene are or have been recommended, and only useful to people whose diets are lacking in that specific nutrient. So again, as opposed to taking a supplement or a vitamin with all of the nutrients, it's important to focus on, okay, where is the deficiency? And let's focus on that one. Again, always make sure that you discuss any vitamin supplements with your healthcare provider. All right, so let's talk about the importance of keeping your mind active. Staying intellectually engaged very likely, or highly likely benefits the brain. So if you enjoy dancing, dance. If you enjoy reading, read. Learn new things, painting, learning new creative, engaging skills may have a particular benefit on keeping your mind active and or reducing your risk for dementia. These activities may protect the brain by enhancing cognitive reserve, plasticity, and compensation for related changes. Things like formal memory training, processing speed training, reasoning training, and anything that improves your mental skills in a particular area trained makes a difference. And again, more study is needed. I was reading the other day, just little things that we do every day out of habit, like brushing your teeth. If you're normally right-handed, brushing your teeth with your left hand can help, create a new habit or a new way of training your brain to think. So doing the habits that we do all the time, just a little bit differently, can help, again, preserve that cognition. Next slide. All right, so sleep well. We know how important a good night's sleep is. I tell my 8-year-old all the time, sleep is important, son. So 7 to 9 hours of sleep nightly is ideal for brain health. It is thought to be an important contributor to brain rejuvenation and repair. If you have a history, or in patients who have a history of sleep apnea, high blood pressure, stroke, heart disease, and memory loss, or medical issues that may occur if that is untreated. Of note, there are some sleep medications that can also increase risk of memory problems. Again, so if you take something for sleep, just make sure we're discussing the risk versus the benefits with your healthcare provider. All right. So stay connected. Keep those relationships going. If you and or your family member enjoyed going out for lunch, prior to COVID-19, grab your lunch, have it at home, get on a Zoom call as we are now, and still connect. Find a way to connect. FaceTime. I know we may not be able to get together as we normally do, but it's been a year and we've done great with learning ways around this. So try not to or avoid social isolation, feeling lonely. All of those things are associated with increased risk of cognitive decline. So stay engaged with friends, stay engaged with family. And as a family member, reach out to family members who may be alone or may not be able to do the things that they once did prior to COVID. And even outside of COVID, if you notice that a family member, they're not doing the hobbies or the things that they used to do, reach out and check on them. So again, all of this may lower the risk of cognitive decline. Thank you so much. I appreciate your time.
Thank you so much, Dr. Pierre, for that information. I thank you both for providing such great insight into brain health disparities in the Black American community and ways that we can promote brain health as we age. You have given us some great points to consider. A couple of them that I thought of is, promoting brain health by using language and culturally appropriate information and messaging, and of course, leveraging this conversation to remove the barriers in brain health inequities. So now I would like to introduce Dr. Kina White, who earned her doctorate in health policy and management from Jackson State University. She has enjoyed a diverse career in healthcare, having worked for the Mississippi Baptist Health System and the U.S. Department of Health and Human Services. Currently, Dr. White serves as Director of the Office of Community Health Improvement at the Mississippi Department of Health. Please join me in welcoming Dr. White.
Thank you, TJ, and good morning to everyone. Hi, Dr. Harper. Good morning to everyone. You can go to the next slide, TJ. And so we've heard today a number of testimonies. We've heard about how impactful it is to have support for caregivers. We've heard about a lot of the ways in which our community environmental factors impact this disease. And so what I want to talk about is where public health fits and what's the role of public health in this crisis. And so it is emerging that Alzheimer's is a public health crisis. It's a new language. It has historically been looked at as an aging issue or just an independent medical issue, but it is truly a public health issue. We've heard that Alzheimer's is the 6th leading cause of death for US Americans. However, when we look at the older adult population, some statistics have it as the 5th leading cause, and some have it as even the 3rd leading cause behind cancer and heart disease among older adults. So it is a critical issue to address. Our role in public health is maintaining cognitive health and ensuring that we promote it as a vital part of healthy living. If you look at this infographic, the course of Alzheimer's disease should actually be looked at across the continuum of the life course. We should be looking at risk reduction. When we look at HIV, cancer, and other areas in public health has a strong role of health promotion and intervention. We should play the same role in Alzheimer's. We should be working towards risk reduction strategies. We should also be supporting early detection and diagnoses, as well as providing safe and quality care for families and individuals impacted with this disease. Next slide. So let's look at a few figures. So some may not know, but Alzheimer's is the most expensive disease in the US, costing more than cancer and heart disease. In 2020, the direct cost to Americans for caring for those with Alzheimer's and dementia was estimated for a total of $305 billion. And so by 2050, as many as 14 million people could be living with Alzheimer's disease, which would cost exceeding $1 trillion. So if you look at the cost of care in Mississippi, this is a report that was ran very recently, so these numbers are current. So a cost for a homemaker health aide in Mississippi, $3,527 a month. adult day healthcare. And as you can see, adult day healthcare, assisted living facility, nursing home, semi-private room, nursing home, private room. Very expensive costs to care for someone struggling with Alzheimer's disease or dementia. And to the right, if you look at the prevalence and costs to Medicare and Medicaid, you can consistently see that as time passes, the continuum is going up. It's increasing. We're not decreasing the impact of this disease on our governmental programs and then our state resources. So there is a critical need for intervention for this debilitating disease. Next slide. So Dr. Shipley talked a lot about social determinants of health. So looking at the economic factors, the environmental factors. Where we live is very important to how we age and our health. And so with Alzheimer's, it is a very under-recognized and underappreciated response to addressing Alzheimer's. Some of you may have heard of things like dementia-friendly communities, looking at the built environment. These are new tactics that are used to try to support the need for individuals with Alzheimer's. Education, health literacy, low literacy, access to healthcare. I know that Dr. Shipley mentioned the difference between healthcare disparity and health disparity, but looking at access to care, the built environment, ensuring that individuals are not lonely and socially isolated. COVID-19 played a significant role in addressing that need. And there was a spotlight on understanding how does the public health play into visitation for assisted living facilities, visitation for home health facilities. There's been a lot of discussion about when is it safe. I don't know if many of you have recently seen the news, but a few long-term care facilities have opened up their doors now for visitors. And so that's very exciting for families to be able to reconnect with their older adults. Eliminating health disparities is a key piece of this work. Ensuring a competent workforce. Gabe mentioned something that was very critical, having not only culturally competent individuals providing, but also people of a similar ethnicity, a similar race, and who actually have the linguistic skills to communicate to their patients. That is very critical in addressing the health disparities for families and individuals with Alzheimer's. Developing policies and looking at partnerships, empowering and educating our nation as to that Alzheimer's is a public health issue and the need for support, and also monitoring and evaluating. The framework to the right is designed to assist not only states and public health entities, but the communities as a whole in really seeing the roadmap of how we will plan to address Alzheimer's disease. Next slide. So this is sort of an infographic of the past and the present. So Alzheimer's disease and dementia, it's not a new diagnosis. However, federal and state support has changed over the years. And so if you see in 2005, that's when congressional support was given for the Healthy Brain Initiative. And as you follow the continuum along, you'll see the behavioral risk factor surveillance system in 2009 added 2 modules to ask questions for individuals as it relates to cognitive decline, as well as caregiver needs. This is very important because this allows states to have individual data to actually look at the needs within their states. Healthy People 2020 included dementia objectives. And if you look at the new iteration of Healthy People 2030, there are increased objectives for Alzheimer's and dementia. And one of the exciting programs of this process is what I'll talk about next, which is the BOLD program, which is a very exciting opportunity that was recently brought to Mississippi. Next slide. So the Mississippi State Department of Health, along with several other key individuals, the Mind Center, Alzheimer's Mississippi, Alzheimer's Association, a number of key individuals worked together collaboratively to submit for an exciting opportunity. And so last September, we began our first year of the BOLD program for Mississippi. And so this program will promote a strong public health approach to focusing on changing systems, environments, and policies to promote risk reduction, early diagnosis, prevention and management of comorbidities, and also to avoid hospitalizations. And there's also elements in the funding to support caregivers or activities to support caregivers. We are using the HBI, the Healthy Brain Initiative Roadmap, to guide our efforts. This is new funding to the Public Health Department. We've never had this funding before. It's a 3-year funding award. We're really excited about it. And also as a part of the funding, CDC awarded 3 public health centers of excellence. These 3 centers of excellence will provide each of the states with additional technical assistance for risk reduction, for caregiving, as well as early diagnoses. So we're really excited to have this capacity be brought to Mississippi. Next slide. So the priorities that we will have as a part of this funding, we will be working very closely with our state plan goal group members and contributors to increase engagement as a state. We want to make sure that the voices and needs of not only the caregivers, but individuals themselves are brought to the table. We will also be looking at our current state plan and identifying ways to improve our plan based on these strategies listed. So we will be focusing heavily on priorities to promote education about risk reduction. We will also be looking at early diagnoses priorities, working with our primary care providers. We will be looking at the prevention and management of comorbidities, and also making sure that caregivers have support. That is very critical and was very much emphasized when this funding was provided, that caregivers have a great need, and this funding will allow us to strategically align our resources to give them that support. We will also be looking at needs of data. For many of us in the public health world, we use data-driven approaches to make our decisions. And oftentimes we don't have county level data to really show where the need is in the areas that we work. And so we will have access to national and vital statistics. CDC actually has a healthy aging portal that we'll be using. And we've created new partnerships to receive county level data to address the needs of Alzheimer's and dementia. For those who may not know, in Mississippi, every odd year, we cycle for the cognitive decline survey for BARFIS. And our goal is every odd year thereafter with funding, we will continue to do that. And then in every even year thereafter, we will survey for the caregiver module so that we can use this data to really inform not only the state plan, but also provide those resources to the community and providers so that we know as a state what needs we have for individuals suffering with Alzheimer's disease and related dementias. Next slide. So this is the exciting part. The National Association of Chronic Disease Directors and the CDC got together and thought about everything Dr. Tarver has said, Dr. Shipley, Dr. Pierre. We know that most individuals suffering with Alzheimer's disease and dementia have other modifiable risk factors, right? They have other comorbidities to address. And so we are very excited to now have integrated brain health and chronic disease risk reduction messaging. So we will be working with our cardiovascular teams. We will be working with our diabetes teams. We will be working with our physical activity partners, our obesity and nutrition partners. And these infographics are going to be distributed in the communities. On one side, you'll see healthy blood pressure, healthy brain. And then on the back, you'll see resources that individuals can use to find more information to talk about the importance of brain health in reducing chronic disease. So we're really excited about this resource. We think that it's user-friendly. It highlights the need to have a comprehensive conversation when we're addressing brain health because it's not in isolation. Brain health is an important part of health promotion and preventable behaviors. So we're really excited about these resources. And we have these available in a PDF format that we can easily share with everyone so that you can disseminate these as well. Next slide. And so thank you guys. Here's my contact information. Certainly have questions. You can place them in the chat, but we're excited about the BOLD grant. It'll give us increased capacity to support the state plan and just really be able to work with our community leaders to make a significant impact on Alzheimer's disease and dementia. So thank you for your time.
Thank you, Dr. White, for your update on the BOLD grant and how Mississippi is working to address brain health along the aging spectrum and to incorporate dementia care and support in initiatives to build age and dementia-friendly communities. We have all learned a lot today, and we see there's a great need to address brain health inequities in Mississippi. It is clear that by working together with the state of Mississippi's strategic plan for Alzheimer's and related dementias that we will achieve improved health and accessible and equitable health care for everyone. By implementing these strategies to keep our brains healthy, we can prevent or slow cognitive decline and ease family, financial, and emotional stress, and decrease the burden on the healthcare infrastructure as a whole. So as we move into this next section on becoming an advocate and engaging our communities. First, I wanted to echo from Dr. White's presentation that we're already cultivating collaborations to leverage data and brain health policy. An example of future work with the BOLD and other CDC cooperatives can be seen here with data from the Us Against Alzheimer's Brain Health Data Hub. Which will allow us to view the impact of Alzheimer's disparities at the county level and hopefully at the zip code level. So why is this data here that you're seeing important for future work? It could be a supplement to the BRFIS data, increased partnerships and collaboration, and to change policy. Looking at the social determinants at our local communities to influence local policymakers at the county and local level, to build a case for investment and a case for public health interventions. So we're very excited about this future work. We can go to the next slide. Today was only a segment of an ongoing conversation, and we hope that you will continue to be a part of it, because each of you can change the trajectory of equitable brain health and access to care in Mississippi. We can see how the Mississippi legislature is recognizing the priorities of the Alzheimer's Party, how caregivers' voices are powerful, and how removing barriers that create disparities in brain health creates a healthier Mississippi for all. So what am I asking of you today in our advocacy opportunities? I want each of you to become a brain health advocate. You can be an advocate in many ways. It can be very simple, because every action you take will help move the needle to bring Alzheimer's and equitable brain health to the forefront of the public health policy. In your email this morning, you received a brain advocate handout to give you ideas, talking points, and social media posts to engage in a healthy brain conversation. If each of us will post on social media today, and I encourage you to use the hashtags brain health equity and hashtag MSLEG, for the legislature, or write a letter to the editor, or speak to your church or community organization. Your voice will become a catalyst for change in our fight to stop Alzheimer's and other dementias. I want to thank you all for your time and attention today. We're going to stop recording shortly so that I can take some of your questions and some key takeaways before we go to help us think about some of these questions and priorities. Briefly, brain health should be considered a public health priority in Mississippi across the lifespan, thinking about it from young adult to aging adult. Build collaborations to provide brain health education from the state to local level. Disparities in brain health and access to healthcare must be recognized in public health planning, as prevalence in the Hispanic and Latino community is growing but remains largely unaddressed in our state and across the country. In less than 10 years, the Latino and African Americans will make up nearly 40% of Americans living with Alzheimer's. We must find ways to address brain health inequities and disparities in Alzheimer's and dementia research, care, and support.